Hey Warriors, have you been struggling with IBS and food? Or has your doctor gave you a paper with the FODMAP diet and you are confused about what to do? Well, this is the episode for you. Sit back, relax, and take notes because this episode is amazing. All right, welcome back, guys. So let's talk about everything podcast. I have a very special guest. It is Jessie Wong. Hello.
Hi, Erica. Thank you so much for
Hi.
having me.
You're welcome. Thank you so much for joining. It's been like a dream come true. I have followed your work a lot on Instagram, especially when I first got diagnosed. So I'm grateful and thankful for you to be joining us today.
Yes, I'm so excited. Thank you for having me.
Yeah, so today we'll be talking about food versus IBS, and the journey between that and the connections and everything from your perspective, from your expertise. So yeah, let's get started. We have a list of questions, and yeah. So the first question is, how can IBS cause you to have a negative feeling towards food?
Oh, wow. We're starting with the hard question first, and one that is very, very common. And I hate to say that as a GI dietitian, and we see it so often, and not just me, it's basically everybody who works in GI as a dietitian, we see this as a problem. And why I say as a problem? Because oftentimes food is recommended as the first line treatment by some doctors, not all doctors, but some doctors will say, why don't you try removing dairy, removing gluten, removing FODMAPs, go low FODMAP and see how you do. Now, all of these elimination diets, they are very hard. I think maybe with the exception of dairy free, because that's a little bit easier, but gluten free, low FODMAP, there's so much nuances to it. And when patients are told to try a diet, they will do that for their IBS. As you know, it's a very debilitating condition. And the problem is when patients try to do elimination diets, they don't know how to go about it. They're looking at a list of foods that they cannot eat. And they try to cut out as much food as they can, but they're really not doing it properly. Right. And in the long run, and oftentimes patients may get a little bit of symptom relief, right, from cutting out certain foods, but not full relief. And they think, okay, food must be causing all of my symptoms, when in reality it's not always the case. And when they try to reintroduce foods back into their diets, their symptoms may come back or their symptoms may worsen. It may or may not be the food. And oftentimes patients will say, one day I eat this food, I'm fine. The next time I eat it again, I'm not fine.
Yes.
Like, it's very confusing. But when patients think that it is food causing them symptoms, it gives them so much fear when they're eating food. And oftentimes, by the time patients find us, right, GI dietitians are already eating like 5 to 10 foods. They're only eating 5 to 10 foods that they feel safe. The rest of the food are out the window because it's caused them symptoms at one point or another, or they just don't know whether it's giving them symptom or not. And, it's really hard for us as dietitians to see this happen again and again and again, because we are dietitians. We, get into the profession because we love food. We love food so much that we put 5 to 7 years of our life, right, in just learning about food. And most of the time, patients don't need to cut out that much food for symptom relief, right? So I wouldn't want to say everybody have a food trigger, because that's not the case, because some people have food triggers, some people have lifestyle triggers. And for somebody to really learn to manage their IBS, you have to understand what's triggering your symptoms and then expand your diet. Now, you do have to understand that underlying causes. I hate to use the word root cause because it's used so often in functional or alternative medicine, which is not evidence-based. Their business is more for selling supplements and tests that are illegitimate, which we can talk about later. But if a patient don't know what's going on in their own gut, right, what's triggering symptoms, whether it is a motility issue, whether there is a true food trigger, which is not just the FODMAPs, it's something else. Or, there's other problems like bacterial overgrowth happening. All of these will contribute to symptoms. It's not just the food. Removing certain foods will help you feel better temporarily, But if you don't resolve the underlying root cause and you try to reintroduce the food, your symptoms will come back. And people blame food for the symptoms when in reality it's not the food, or mostly not the food. Sometimes it is the food. I don't know if it's clearing things up or making it more complicated. But another thing I also want to say too when I'm talking about this is IBS is also very complicated. There are 4 different types of IBS: IBS constipation, IBS diarrhea, IBS mixed bowel type, and IBS unclassified. Actually 5 types. There's also post-infectious IBS. And treatment for each of these varies. So, can cutting out food help all of these different subgroups of IBS? Not necessarily, and we often find people going low FODMAPs, can make constipation worse. So patients who suffers from IBS-C may get worse symptoms in the long run. It does help a lot when it's IBS-D because we are talking about removing certain substrates like food that irritates the gut, right? They irritate the gut. They don't cause other issues, but they do irritate the gut as they move through the gut. Yeah. Very nuanced.
I didn't know there was 5 types. I always heard like IBS-C, IBS-D, and IBS-M, but never the other 2. That's interesting.
Yeah, it's very nuanced. And then I want to say too, within IBS diarrhea, there are many different root causes to why a person have diarrhea, right? So there is overflow diarrhea, which is actually caused by constipation. There are fat malabsorption diarrhea, which is also called bile acid malabsorption, or bile acid overflowing into your colon causing diarrhea. So about 19% of IBS-D patients may have bile acid malabsorption. And then there's diarrhea caused by exocrine pancreatic insufficiency. Now, these are the people who may have stool that it's very smelly. Actually, both EPI stool and bile acid malabsorption stool, they can be very smelly. They can be different color than normal. And then there's, again, food intolerance diarrhea. That is actually triggered by food intolerance. And there are different types of food intolerances that can trigger that. So, again, even within different subtypes of IBS, there are different root causes to it. And funny enough, well, I don't know if it's okay to say, but we have a podcast called the IBS Nutrition Podcast where we break down, the different types of IBS diarrhea and explain what each of them are and what to do to get the care you need to actually find relief and targeting the root cause, right? Not just removing food, but actually understanding what's going on in your body. Now, when it comes to IBS constipation, right, there are so many reasons. Again, somebody would be constipated. It could be from diet or lifestyle related, right? Not drinking enough fluids, not getting enough fiber in your diet, and not moving your body enough. Now, that's one. And then there are people who have slow motility induced diarrhea that is caused by, slow gut motility. And then there is secretory diarrhea where, when food is moving through our intestine, we secrete different substances to help it move along easier, especially when it gets to the colon. And sometimes when that malfunctions, that causes patient to have constipation, right? And then there's pelvic floor constipation. And then, of course, there's other type of constipation as well that contributes to constipation. So there are so many different reasons why somebody have issues within, different types of IBS, like IBS constipation, IBS diarrhea. And then mixed bowel type, again, is a mixed basket of all of these things combined. And you're like, what are we looking at here? And how do we treat patients? And the easiest thing sometimes to tell patients to do when you can't figure it out is go try a diet and see how you do. And that is something we hear very often. And I really wish doctors don't do that or dietitians don't do that. And what we think is very important is refer these patients to a GI specialized dietitian where we can look at all of these things, but also we can teach the nuanced diet to the patient if they are a right candidate. We hate putting people on diets unless it's absolutely necessary, right? And with IBS, I think, of course, the number one recommendation is the low FODMAP diet. Beyond going gluten and dairy free, right? The low FODMAP diet has the most evidence to it, but it's also one of the really tough diets that you have to implement. You are removing short chain carbohydrates. These are fibers, that goes into our guts, and they're actually good for our gut microbiome. And what research is showing, well, what research is showing is that long-term elimination of these substrates, these short-chain fibers, can negatively impact our gut microbiome. And if
Mm,
patients stay on the low FODMAP diet for too long, it can make them more sensitive to the
mm.
FODMAPs down the road. So we
Wow.
do see a significant amount of patients who have been on the diet for a few months to a few years to even longer than that, sometimes like
Mm.
10 years plus. And when we try to reintroduce the FODMAPs, sometimes they just don't tolerate the larger quantities. But what we usually tell patients, right, eat the small amounts that you can tolerate right now, because
Mhm.
that's going to feed the gut microbes that can help you break down this group of FODMAPs. And in the long run, when you have more of these type of gut microbes, you will be able to tolerate a bigger quantities of the FODMAPs that, you may not tolerate at this time.
Mm.
And yeah, there's so much nuance to it. But
Yes.
yeah,
Yeah, because
in clinical terms, yeah,
when
tell
I
me.
was diagnosed with IBS,
Mhm.
first I had a whole bunch of diarrhea and I was like, what's happening? What's going on? And I went to my primary care and then they referred me to a gastro doctor. And they
Mhm.
were like, okay. And so my first experience with this doctor was not that great. He basically like blew me off and was like, you're too young to have any problems. Like, you're fine. It's just stress. Like, you're fine. It's just anxiety. And I'm like, no, like something's really wrong. Like something is going on. Like I'm having diarrhea every single day. I'm in the bathroom for like 3, 4 hours. Like the
Mhm.
pain is really bad. And so we finally got a colonoscopy and they were like,
Mhm.
oh, you're fine. You just have a hernia. And I'm like, you're fine. And I'm just like, no, but still, like I'm suffering. And then I went to another one and it was like, you may have IBS. Like you may have IBSD. Like you and so we went with that. We did the endoscopy, we did like blood tests and everything. And of course the blood test came back normal and everything. And they were like, yeah, we think you have IBS. And so I kept going with the gastro doctor and they gave me the piece of paper with the FODMAP diet and it was like, here you go. And I was like, okay. And I saw all this like the diagram and things that need to cut off. And I'm just like, this is scary. And I really never got the understanding of what the FODMAP diet is and how to introduce and reintroduce. And so during my journey, I have been confused of what to do with my IBS like diagnosis and also how to handle it because I'm just like, I'll just give it a piece of paper and then sit on my way. So hearing you say like there's different things and I'm like, now I'm completely understanding like my IBS like diagnosis and it's very interesting and very cool and yeah, it's a lot.
It really is a
Yeah.
lot. And now I have to say something. I think a lot of patients can relate to your story because we hear this again and again and again. I've seen multiple doctors, they've run all the tests, everything came back normal. I feel like I'm written off by the doctors. Now, here's one thing that is really important for listeners to understand. It is important for your doctors to run all of these tests because they need
Mhm.
to rule out other overlapping conditions as IBS. With IBS, what we need to get you a diagnosis is your symptoms. You have to have certain symptoms for a certain period of time, and you have to rule out other conditions first
Mhm.
before getting an IBS diagnosis. So oftentimes patients will feel like, okay, I'm written off by my doctor. When in
Mhm.
reality, that is the process of getting you the diagnosis of
Mhm.
IBS. And patients feel really despaired when they are like, everything is normal.
Mhm.
They say nothing is wrong with me. I want
Mhm.
to tell you this. If everything comes back normal with your test, this is a really good sign that diet modification and lifestyle modifications can help you get you back to your baseline, to whatever
Mhm.
your baseline would be so that you can actually live, your life to the fullest, even
Mhm.
with an IBS diagnosis. It's not a death sentence, but really telling you, hey, we can do things
Mhm.
that is non-invasive, that is maybe may or may not require medication depending on the patient, because sometimes medication works wonders for certain patients, right?
Mhm.
Sometimes no, not so much.
Mm-hmm.
But diet and lifestyle therapies can be really helpful for patients, and GI psychology therapies as well for certain patients. So everybody is different, but don't give up. Even if you have seen multiple GI doctors, or even if you've been to multiple GI dietitians, or
Mm-hmm.
find somebody who actually understands and help you, peel the layers
Mm-hmm.
one layer at a time to see what is contributing to the symptoms.
Mm-hmm.
Now, I heard you said, you were given a page of the low
Yes.
FODMAP diet, and you're like, what the heck is this? Are these
Yes.
all the foods that I need to cut out?
Uh-huh.
Now, I want to tell listeners here, I'm going to explain what the low FODMAP diet is, but we also have an amazing free resource for anybody who wants to learn more. Don't implement it just yet, but learn more about it. So if you go to ibsdietitian.com/resources, we have a low FODMAP starter guide for anybody who has been recommended a diet and frustrated with it. Our approach is a little bit different than what you get from doctor offices,
Yes.
because we know patients get very frustrated when they look at a list of you cannot eat these foods.
Yes.
And what we want to change is, don't look at it from a restriction lens, look at it from what you can have. Go use my grocery list, highlight all the things you like to eat there, and go shop with that list and go eat all of that list. So you're not thinking of things that you cannot have, but you're actually looking at things that you can actually have on this diet. Or maybe, if you've been recommended to try it, right, use that to try it out for a few days or 2 weeks and see how you do. So you're not thinking, restriction, but actually eat the things I actually am allowed on the diet, so you don't feel as restricted. But nevertheless, it is a very difficult diet.
Yes.
Now, the low FODMAP diet has 3 steps. The first step is elimination phase. We don't, how should I put it this way? So this phase, technically, when it was first researched and educated to dietitian, is that we help patients remove a significant amount of FODMAPs in their diets and bring their symptoms down to baseline. And this phase is about 2 to 6 weeks.
Gotcha.
Now, for somebody who don't know really how to teach this diet, that's all they're going to tell you. For an experienced GI dietitian, when we tell you to go low FODMAP, we are not just waiting for that 2 to 6 weeks. We are actively looking at what is going on in your gut when you're not consuming things that are irritating your gut. Because when you remove the gut irritants, right, the FODMAPs, which some of them draw fluid into your gut, causing that gurgling and gushing and maybe diarrhea. But all of the FODMAPs are rapidly fermentable, meaning they get fermented by our gut microbes when the FODMAPs reaches our colon. And that can cause gas, that can cause bloating, distension, and a lot of discomfort. So they are gut irritants, but they are not really, they're not the root cause to why you're having all these symptoms. Something else is causing your gut to act differently, so that you're experiencing the symptoms. So if you're working with a trained or very experienced GI dietitian, or even GI doctor or nurse practitioner who understands this, when you go low FODMAP, they are investigating what else is going on in your gut during this time, because it's a lot easier to see through the noise when there's no noise, to see what your baseline is, what is truly going on. And then we do interventions to help whatever is happening. If it's improving motility, then we do interventions on that. If it's improving gut-brain connection, then you can work with a GI psychologist on that. And then there are also lifestyle interventions that you can do to improve your gut-brain connection, if you want to do that by yourself. And there are also apps to help you improve the gut-brain connection. But, a trained dietitian, a GI dietitian, would be doing that step instead of saying, okay, I'll see you in 6 weeks and then we'll talk about reintroduction. No, we really want to be, asking you about your symptoms, how symptoms are changing when you're low FODMAP. What other symptoms are you experiencing at this time that we know are not caused by the FODMAPs? Then we can really dig deeper and peel the layers and see what's happening. Then resolve the root cause. Then we reintroduce the FODMAPs. If you don't resolve the root cause of what is going on, right, and you try to reintroduce the FODMAPs, most people are not going to tolerate the FODMAPs very well. They are gut irritants, but they are not ultimately why your gut is acting weird around FODMAPs, because normal people can eat FODMAPs, they are fine. But for those of us with IBS, myself included, if I'm very constipated and I eat FODMAPs, they're gonna bloat me, they're gonna cause gas, they're gonna cause very stinky, smelly gas, and they can cause pain, right?
Yes.
But not necessarily them are the problem. Constipation is my problem. I need to resolve the constipation before challenging the FODMAPs. So very long-winded explanation to what the low FODMAP diet is and how actually to implement it. And what we see in our clinic too is oftentimes patients are being referred to a dietitian. They may call themselves a GI dietitian, or they might be a general specialty dietitian who usually teaches diabetes, hypertension, kidney disease, and they have heard of the low FODMAP diet and they're like, okay, here's your diet, go try it out and see how you do. But without the understanding of, the nuances to the diet and the other work that you need to do with your patients when your patient is on the diet. Now, the third phase or the second phase of the low FODMAP diet is reintroducing FODMAPs. And what we do is we reintroduce the FODMAPs group by group, and we usually do it over 3 days for each group of the FODMAPs. Let me see. I don't know if you're going to have a recording of this image going up with your podcast, but I can show patients what it kind of looks like.
Yeah.
Oh, we have a IBS patient toolkit. I think patients are usually very frustrated, really frustrated with an IBS diagnosis and often don't really understand. We have a toolkit. This was developed for providers' offices so that they can explain it to patients better. So nobody is, as frustrated, because trying to cram all this information in a 15-minute session is almost impossible.
Yeah.
But if you want, go get our toolkit. It's again, ibsdietitian.com/resources. But I want to show you here, reintroducing FODMAPs is a systematic you have to follow a systematic way. So for example, one group of the FODMAPs I have listed here is excess fructose. There are certain foods that you can choose to challenge the excess fructose group of FODMAPs. And on here I have listed honey, mango, asparagus, orange juice, and sugar snap peas. You can just choose one food and then you do it over 3 days. The amount of food you have to eat is very specific. Every food has a different amount because FODMAP content between these foods are different. But over the 3 days, we also measure patients' symptoms when they're eating these foods and see how much of the foods or the FODMAP group they can tolerate. A lot of the times when you've resolved the root cause of the gut symptoms, patients will be able to tolerate a full serving of the FODMAP groups with no problem. Well, excess fructose is an easier one. Usually people have more problem with garlic and onions, but most of the time, once you resolve the root cause, you'll be able to eat a small amount of garlic and onions. So you don't have to worry about it when you go out to eat or, something else happening. Yeah. But it's very tricky. And, you have to do it in a systematic way. And in our clinic, we actually have 12 groups of FODMAPs that patients reintroduce and challenge. So that, we understand your tolerance level and we can expand your diet to the fullest, right? The goal is really to expand the diet to maximum without triggering symptoms. So that's phase 2 of the low FODMAP diet. Okay, the third phase of the low FODMAP diet is really expanding the diet to the fullest that patients can without triggering symptoms. And is that what you were told when you got the low FODMAP diet recommendation?
No, I'm just getting a sheet, and then it was a list of foods that I cannot eat, and then they was like, all right, see you in 6 weeks. And I was like, okay. Like, that was it. There was no explanation. There was no diagram. There was like, no.
Was it a dietitian that you went to?
No, it was a GI doctor.
Okay.
And it just,
yeah. I'm so sorry, but that's just where we are. Yeah. Oh, and I have something really exciting to say. Hopefully there is a IBS nutrition guideline in the pipeline that actually we are starting to write for the next recommendation. That's gonna come out in the next 2 years. Writing a guideline is a long process, but there is one in the pipeline the Academy of Nutrition and Dietetics is actually working with the American Gastroenterology Association in developing the guidelines. So hopefully with a dietitian on the committee or on the panel, it will be a lot better,
Yes.
and can, shape the next generation of care for IBS patients.
Yes, I'm so excited. That's amazing. Like, that is amazing. Wow. Wow. That's good. I'm happy that IBS is finally getting like a little bit of shine because like when I got diagnosed and they were like, "What is IBS?" Like a nurse asked me and I was like, "Wow, like a lot of people don't know what IBS is." Like and they're just like, "Yeah, I don't know what that is." They know what like Crohn's and all that, but IBS they're like, "Yeah, no, we don't know what that is. We don't understand that." Or they just think it's just like a bad stomach ache. Like and I'm just like, no, it's more than that. It's
Mhm.
more than that. So for the food triggers, what main food triggers do you see in your line of work? I know you said like garlic and onion, which sometimes I have trouble with that, but what other food triggers have you seen?
So garlic and onion would be in the FODMAP groups, and those are fructans.
Mhm.
And then beans and legumes sometimes are also harder to digest for patients. Again, these are in the FODMAP groups. And dairy, but now this is an interesting thing because a lot of the times when people are having food issues, I see it in my friends as well. The first thing they cut out is dairy.
Yes. Hmm.
And unfortunately, or well, let's say it this way, fortunately, most people with IBS can actually eat dairy. They might not be able to tolerate lactose, right?
Hmm.
Lactose is the sugar in dairy.
Hmm.
But oftentimes, when people have gut symptoms, they cut out the whole dairy group altogether. And that can be extremely restrictive because dairy is in everything, and dairy is delicious, it's nutritious, it's really good for our bone health, and in general for our mental health as well, because
Hmm.
dairy food is eaten all around the world,
Hmm.
and in many cultural dishes. So if you are listening, don't just cut out dairy.
Hmm.
Try low lactose dairy and see if you tolerate it. So lactose could be a trigger for a lot of people with IBS, more so in patients with IBS diarrhea, not so much in patients with IBS constipation. It can still cause more gas and bloating, but it does have a osmotic effect, so it might actually help stool move out of your system a little bit faster.
Hmm.
But dairy or lactose could be a trigger.
Hmm.
Some of the other ones I hear are in the polio group, which includes sorbitol and mannitol. So these are the mushrooms, the apples, your avocados, your
Hmm.
peaches, which is really sad because I live in Washington State, and we are one of the biggest apple growers in the country.
Hmm.
And when people have IBS, they cut out apples. I'm like, but apples is so good for you,
Yes.
and it really is good for you. So don't just cut them out. Maybe eat the smaller quantities and see how you tolerate it.
Mm.
So those are all in the FODMAP area.
Mm.
Right. And then there's also gluten.
Mm.
Gluten is a debated topic, and I'll share with you what we see in clinic and what research says.
Mm.
So again, gluten is something that patients cut out automatically when they
Mm.
think they have gut symptoms or when they think gluten is their trigger. There are research out in Australia that says actually most patients who cut out gluten are not gluten sensitive. In turn, they're actually reacting to the FODMAPs in wheat, which is fructan. So it's the same FODMAP that is in garlic and onion.
Mm.
However, they are, I think, I can't remember the number. I think it was about 60% of patients don't have gluten intolerance. But what we also see in clinic are people do have, non-celiac wheat sensitivity. So these are people who test negative for celiac and they react to gluten. And how
Mhm.
you differentiate whether it is gluten or fructan is, you have to cut out both foods, fructan and gluten, and then challenge, one at a time to see what you tolerate and what you don't tolerate. And usually we have patients challenge fruits and vegetables with fructan to see if it's a fructan intolerance, right? Could they tolerate garlic and onion? Now, garlic and onion are separate areas. We don't, when it comes to testing for fructans in FODMAP groups, we test it out with multiple food groups because we know garlic and onions are more potent and more people tend to react to it, but they don't necessarily react to it if it's a fructan from fruits and vegetables, for example, in blueberries.
Mhm. Hmm.
Yeah, but then gluten is different. Gluten is a protein, whereas FODMAPs are carbohydrates. So you really have to differentiate the two to understand what may be triggering your symptoms. And we see a lot of patients actually cut out everything. They cut out FODMAPs, they cut out gluten, they cut out dairy because their IBS symptoms are just so debilitating and they want relief. And the easiest thing for them to do is to cut out food.
Hmm.
But anytime they eat, symptoms come back. Now,
Yeah.
when it comes to the gluten-free diet, right, it is one diet that I hate teaching. We have to teach the diet in our clinic because we also see celiac. We also see patients with non-celiac wheat sensitivity. Usually we are the person who catch patients with non-celiac wheat sensitivity. We look at patients' family medical history, their own medical history, looking at their tests. We also advocate for our patients to get more tests if necessary to rule out celiac once and for all.
Hmm.
And then also look at, the big picture, and then we do the food challenges. And the gluten-free diet is really hard, as the name implicates. You have to be gluten-free. It's not a low-gluten diet. And what most patients tend to do when they put themselves on a gluten-free diet is actually a low-gluten diet. Because gluten-free, you have to be looking at labels.
Hmm.
You have to be talking to restaurants, asking them about their protocols. What are your, kitchen protocols to prevent cross-contamination or cross-contact from happening so that you can keep me safe?
Hmm.
Um, yeah, it's, and gluten is everything in our
Yeah.
society.
Yeah.
It is one of those diets that every time I have to teach it, my heart breaks for the patient a little bit. It is, I think, too, it is one thing for a patient to choose to be gluten free.
Hmm.
It is a different thing when a patient now sees that my body is reacting to it. I don't have a choice anymore. I have to be gluten free. And
Hmm.
the gluten free diet is a lot harder than what most people anticipate.
Hmm.
But, you do need to understand what is triggering your symptoms, right? And if gluten is the trigger, which it causes an immune reaction in the body, it's not an allergy reaction, it's not a celiac reaction, it's a different type of immune reaction that people get symptoms for. And you do have to, understand if that is your trigger. If it is, then you have to remove it for life. So unlike the low FODMAP diet, there is challenge and eating FODMAPs at the level that you can tolerate. With the gluten-free diet, it usually means you cannot tolerate gluten moving forwards. You
Hmm.
have to cut it out to maintain symptom remission.
Hmm.
But on the bright side, if a patient do have non-celiac wheat sensitivity, when they cut out gluten, we do see their gut starts healing. And when their gut starts healing, that's when we can actually add more FODMAPs back into their diet and they can tolerate more FODMAPs. So oftentimes, I'll give you an example. This is actually a healthcare provider. Her name is Jessica. She lives in the Pacific Northwest and she is a healthcare provider and she was dealing with a lot of diarrhea, like 5 to 10 bouts of diarrhea per day. It made her very afraid to leave her house. It made her afraid to just going to work. And it made it very difficult for her to do her job because she is a provider. She's seeing patients all day long and she have to run in and out of the bathroom because of her IBS symptoms.
Hmm.
She used to be a very outdoorsy person. She loves going hiking. She loves going to restaurants. It just made her world shrink,
Yeah.
which we hear that so often from IBS patients.
Hmm.
And she went to her doctor and then also went to a GI doctor, which, again, did all the testing. Everything is fine. She then went to a naturopath who diagnosed her with SIBO and treated her with antibiotics. Now, I have to, warn patients listening here, don't go to a naturopath.
Yeah.
And one thing, I think for her case, very lucky for Jessica is that she is a healthcare provider. So when she got the SIBO treated the first time, she felt better. But then SIBO came back very quickly. And then they were doing another round and I think second and the third round of antibiotics. And the antibiotics is starting to not work for her in her case. And she was very concerned as a healthcare provider. And then the naturopath said, go do the low FODMAP diet. And she, upon looking at the diet, she was like, I can't do this by myself. And that's when she joins my program. And because she it's not something she could do by herself. And to anybody listening, please don't attempt the low FODMAP diet by yourself. It is very hard. So when she came, right, we did Everything I do with a patient would be, looking at their medical test, family medical history, her medical history, and then assess to see, what is really causing her symptoms. Because even when she's low FODMAP, she's still running to the bathroom a little bit. Did she have SIBO? She did have SIBO, but SIBO wasn't the problem. With SIBO too, you have to understand what is causing the SIBO. And we found that she actually has non-celiac wheat sensitivity. So she's been tested out of celiac disease and she has non-celiac wheat sensitivity. And gluten was the reason why she was running to the bathroom multiple times a day. Now, prior to cutting out gluten, she could not tolerate any FODMAPs. Anytime she eats garlic and onion, she's in the bathroom within half an hour. Anytime she eats any high FODMAP, she's running to the bathroom. So, but after we removed gluten from her diet, now we don't make assumptions, right? We don't make assumptions. We really do remove and then test and see her body's reaction. And when we removed gluten from her diet, we saw an improvement pretty quickly within 4 weeks. I think her bowel movement was somewhat back to normal and get to baseline. And then we did a challenge to see, did she tolerate it? How much of gluten did she tolerate? So over 4 days, we did a challenge and the diarrhea came back, I think the second or the third day. She didn't finish the full challenge because it was very obvious her body was reacting. But after that, we continued to let her gut heal, and then we did the FODMAP challenges. So prior to removing gluten, she couldn't tolerate any FODMAPs. But afterwards, she was able to eat all of the FODMAP groups, including garlic and onion, back into her diet. So, this is one case I like sharing because, it gives people hope that when you get to the right diagnosis, you can eat the food you love again. But if you do have a real food trigger like gluten, which is, not FODMAPs, right, then you do have to identify it and remove it from your diet. Now, that's one. And then let me also share a different patient story where she didn't have any food intolerance because, I hate to tell people something, you have to cut out food to get to symptom baseline. That's not true for everybody, especially when it comes to IBS. And this is somebody, her name is actually Erica. I love her dearly. We are friends on Instagram. We worked together in 2020. She's one of the first people in my small group program. So we launched the small group program in 2020 and she was in our first group. Now she was somebody who was struggling between constipation and diarrhea. But of course she was diagnosed with IBS diarrhea because that was the more significant symptoms that she was experiencing. And she would be living her life, everything would be okay, and all of a sudden she would need to run to the bathroom and she would be in the bathroom for hours, like literally hours. And then the cycle would start again. She would, get bloated and more bloated, more and more constipated. And she would be really worried about whether she need the bathroom or not. And it made her afraid to leave. And I think what made her join the program was she went to France with her husband and she did not enjoy that trip at all because she was thinking about where is the bathroom all the time. And then also afraid of eating any food because she thinks that, well, if I eat this, will it make me go to the bathroom? Where is the bathroom at? Let me map out my, exit, my emergency exit first. And so when she came, we looked at her bowel patterns and I said, I don't really think you have IBS diarrhea. I think you have IBS mixed bowel type. You are going back and forth between constipation and diarrhea. And a lot of the times people do still have a bowel movement every day. But if that bowel movement is not a full evacuation, then you are still backed up. You're still constipated. So that was her case as well. She wasn't not going to the bathroom, but she wasn't going a lot, and it wasn't going enough to have that full evacuation. And it continued to cause her symptoms. So we did a series of things to really improve her motility. We upped her fiber intake slowly. We upped her hydration level slowly. And then we helped her, create a routine, a morning routine that works for her body so she can have a complete evacuation before she go to work. Or maybe if she's at work, she can still, have a complete evacuation and then she doesn't need to worry about her bowels all day long. And for people with IBS-C or IBS mixed bowel type, that's me too. If I don't go to the bathroom for one day, I do feel the fullness come back. That's, constipation is my problem. It's not the food causing me problem. And
Hmm.
for Erica, once we resolved, the other Erica that I'm talking about, yes. Let's say your name is like, oh, yes, you're Erica
Yes.
too. But for Erica, once we resolve that incomplete evacuation issue and really work on full evacuations daily, her symptoms resolved. She didn't have any more bloating. She was able to eat all of the vomit groups. She didn't have one group that she didn't tolerate.
Hmm.
She definitely did not have a gluten intolerance.
Hmm.
And she was, feeling so much better and no more food fear and not, worried about leaving her home anymore.
Hmm.
And, so I really want to tell people here that not everybody has a food trigger. Don't just cut out food. And if you are suspecting a food trigger, you need to work with somebody who understands all the nuances to
Hmm.
help you work through it, to identify your real trigger instead of saying, well, you can't tolerate all these things.
Hmm. Yeah.
Yeah.
This is very like I love this because that second story with the other Erica, that's kind of like how I am. Like I was diagnosed
Hmm.
with IBS diarrhea, but then now I have constipation and diarrhea. And so I'm just like right now I'm in like the constipation phase. Like I'm just like I need something to help me out. So I actually was like, they gave me laxatives, and
Hmm.
with the laxatives, it sent me straight back to diarrhea, like really
Oh
fast.
no.
Yeah. So I'm in that like trying to find out that groove of what can help me, what doesn't help me. Is it food? Is it not food? Is it stress? Is it like,
Mm.
all of that. So this is very helpful. This is
Well,
very,
I
very.
also want to say with laxative, there are many different class of laxative. Over-the-counter laxative, there are three different types. There's stool softener, there's osmotic laxative, there's stimulant laxative. These are all very safe and effective. We don't usually recommend stool softeners because they don't work very well, but osmotic laxative and stimulant laxative can be really helpful for
Mhm.
patients with occasional constipation. But now, if you try it, it doesn't work for you, then maybe talk to your provider. There are prescription laxatives as well, prescription IBS-C medication that can be really helpful with gut motility. But like I said earlier, right, there are different types of constipation. You have to match your type.
Mhm.
Is it a motility issue? Is it a secretory constipation, right? To the right medications that can be useful for you. And find the right dosage that works.
Mm.
Oftentimes, when we hear people say, "Oh, a laxative doesn't work for me," but then it's like, have you tried a different dosage? Have you worked with your providers to dose up and down to see where your sweet spot is? Right.
Mhm.
So those are things to think about. And before we go, I also want to caution listeners about something as well. And oftentimes what we see in clinic is people go buy a lot of supplements thinking that what they really need is to find that one supplement that can cure their IBS. There's no such thing out there. And if you've been listening, earlier we talked about so many different root causes to why patients have IBS symptoms, right?
Mhm.
There are certain supplements that can target your root cause and can be very helpful, but
Mhm.
most of the supplements in the market don't have any evidence that they actually do that.
Mm.
um, so be very careful. And if a supplement says they can help you with constipation, bloating, your skin will glow after this, your brain fog will be gone after this, I would
Mhm.
say run, don't buy
Mhm.
it. And another thing I also say too, the more expensive a supplement is, the less likely that they will have evidence that they
Mhm.
actually help. A lot of the times they have really good marketing.
Mhm.
That's where the money is going into. It's not necessarily the research, the what is that, the efficacy
Yeah.
of the supplements. And the big difference between medication and supplement is the regulation, right? Medication actually is highly regulated. You have to jump through so many hoops with the FDA to get a medication approved for over-the-counter use, for pharmacy or prescription use. Whereas supplements actually do not come with any of that. Anybody can put a label on a bottle and sell you as a supplement. So be very careful of the supplement market. It is multiple times bigger than the pharmaceutical market. And that's what, all I want to say.
Yeah, absolutely. Thank you
So
so much.
beware of that. And another thing, I want to share too before we go is don't fall for the scam test. that are out there. There's the food sensitivity test. There's some of it is called LEAP. Some of it is called MRT. There are many names to it. These food sensitivity tests don't have any valid research on them. In fact, the American Association of Asthma, Allergy, and Immunology, so AAAAI,
Oh.
put out a statement on food sensitivity tests debunking them. So if you want to look that up, look up AAAAI and food sensitivity tests. You'll be able to see their official statement debunking them. And these food sensitivity tests, whether it is a blood test or a breath test, they just don't yield consistent results. And more importantly, they're not accurate. So again, when it comes back with so many foods that you are eating, people are again cutting out foods. They're being very afraid of these foods, thinking that these are my food triggers. When in reality, no, they're not your food triggers. You're being lied to by something that is not validated, is not the right tool to use. And if you see or hear a provider selling these kind of tests, you should run. You should not work with them. And unfortunately, there are a lot of dietitians, providers that actually use these tests. It breaks my heart every time. Now, I don't want to alienate any providers that may be listening to this, but we do have a podcast episode on the IBS Nutrition Podcast, episode number 6 with Dr. Andrea Love, that break down the science of these tests and why they are not valid. So food sensitivity test is one of them. Gut microbiome testing is another one. We don't know what to do with the data that is presented to us. Usually with these companies, when you do these tests, it will come back with the results saying, oh, you may have an excess of this kind of microbes or deficient of this kind of microbe. And the next step would be selling you supplements to try to fix the problem. When in reality, we just don't know how to interpret these results. And, the business model is test, supplement, restrictive protocol, and then test again, and then a different type of results. And what research found was really interesting about this is that the researchers sent the same sample to the same lab twice, and the results came back different.
Wow.
I know, which is why, the technology may be or maybe not ready, but our understanding of the gut microbiome is not there yet. So therefore, we cannot use these, to guide our clinical guidance or intervention. So be very aware of that. And there are, again, a lot of providers who do these kind of tests. And it hurts me to even say that, they are not valid. Oh, another thing, the last test I want to point out, there are so many bogus tests out there, but these 3 are the ones that I see very often. The hair mineral test or hair mineral analysis test. There's one dietitian who sells these tests, and she teaches other dietitians how to, interpret results on these tests. And what they claim is that, the test will tell you what mineral you are deficient with. And then, of course, they're selling you the supplements to fix that deficiency. When in reality, we cannot use your hair sample to tell you what mineral you're deficient with. That's just not how it works. Yeah. And it was debunked in the 1980s. However, people are still falling for it because for IBS patients, right, you're desperate for help. Yes. You want to get the test done. You want something to show up as, positive so that you can tell yourself and your providers, like, look, I'm not making things up, but these are not the tests to do, and it is okay to have negative tests. You are not making up your symptoms. IBS is very real. You just need to find the right providers to help you. With hair mineral tests, what they can test for is actually drug use. I think that's the only valid reason, to use that test. It should not be used for anything else because it's not valid. And Dr. Andrea Love actually debunks that on our podcast episode. So IBS Nutrition Podcast, episode number 6. Listen to it, learn more about it, don't fall for it. And we have seen patients who work with naturopath, one of our current patients, he's done 7 rounds of testing with a naturopath. That's a lot and a lot of money and time wasted, not actually addressing what is really going on. And supplement after supplement, rounds and rounds of supplements. I can't even tell you how much money he spent and how much time he wasted, and it was not getting anywhere. So, if you see any of these, run. Don't fall for it.
Yeah.
Go back to your GI, work with an IBS dietitian or work with a GI trained psychologist if anxiety, stress, are the bigger problem for you.
Mm-hmm.
But if you suspect a food trigger, work with a GI trained dietitian who understand the nuances of implementing the diet and also the nuances of different GI disorders.
Mm-hmm.
IBS is such an umbrella term. There's so many different conditions that's embedded in it. You really have to be an expert in GI to understand, how to help your patients.
Thank you again for all this information. I greatly appreciate it. I'm gonna use it to help me in my IBS journey because, yeah, like you said, it's a lot.
It is a lot.
But before you go, tell us where we can find you, where we can find your podcast before we go.
Yes, you can find me on social media. My Instagram handle is ibs.dietitian, or you can find me on ibsdietitian.com. And we also have a very useful site. It's called pooppedia.org. So this is a website that I use my patients' pictures to create to educate patients on stool consistency and the Bristol stool charts. So for you to learn more about what, poop looks like, because I think this is a very taboo area that people don't talk about.
Yeah.
When I got into GI, I see some really weird poop, and I'm like, what class of this is it on the Bristol stool charts? And I'm like, if I don't know it, how do other people know it? How are the GI doctors trained? And then there was no such resource. And so I created pooppedia.org, and I want to give a shout out to all of my clients and patients that gave us permission to use their pictures, because it is really helpful for patients to better understand what is going on in their body and what are things that they can do to help improve the stool consistency. And then, of course, I have a podcast. It's called the IBS Nutrition Podcast. You can find us on any platform, Apple Podcasts, Spotify, YouTube, and I think on Amazon as well. So anywhere you listen to podcasts. Thank you so much for having me, Erica.
Thank you. Bye.
Bye.
Hey, warriors. Thank you so much for listening to today's episode. I hope you enjoyed and learned something from it. Get ready for our next episode that is coming out April 24th. See you guys soon.